شكرا. السلام عليكم ورحمة الله وبركاته. Thank you for the organizers and thank you for the kind introduction. And it's difficult to talk maybe after Prof. O'Connor's. So hopefully I will keep you engaged with this talk. So the outcomes of the high-dose methotrexate for a CNS prophylaxis. And I think this is one of the talks that I think we could just start with the conclusion slide rather than just going and say there is no randomized clinical trial yet. But however, despite the debate and this topic still unfortunately have that dilemma of when to give, what to give, and is there also evidence into the efficacy of the methotrexate, especially the high dose. So I'll be talking about just giving introduction about the CNS relapse and diffuse large B-cell lymphoma, primarily about the predicting the risk, what are the models that we have to predict the risk of the CNS relapse, clinical markers and biomarkers, and also role of intrathecal and role of IV high dose methotrexate, timing of high dose methotrexate, and then we'll just go over our experience at Princess Neuro-Oncology Center. So the secondary CNS relapse in diffuse large B-cell lymphoma, and we are not talking about a synchronous CNS here, we are talking about a secondary diffuse large B-cell lymphoma with a CNS involvement, about on average 5% of patients with a diffuse large B-cell lymphoma. And that due to maybe the hematogenous route, about the direct infiltration sometimes from the masses, especially close to the CNS. It could be through the neurovascular axis. And it affects primarily about 70% or more the parenchyma, meninges, CSF, or the eyes. With exception of the primary testicular diffuse large B-cell lymphoma, the time to the CNS relapse is typically within 6 to 9 months. And that's why most of the people saying that this could be occult, a CNS involvement at the time of the presentation, and it's not a relapse disease. As you know, a poor prognosis for those patients who developed secondary CNS involvement post even intensified therapy. So what are the models that we are using to predict the risk of the CNS recurrence in a diffuse large B-cell lymphoma? This is a CNS IPI. This model was developed by the German group, non-Hodgkin lymphomas group, and was validated by the British Columbia Cancer Agency. And primarily, it says that risk factors which we are using for the IPI, for the diffuse large B-cell lymphoma, age more than 60, poor performance status, elevated LDH, advanced stage, and multiple extranodal involvement, and they added renal or adrenal involvement. And they stratifized the patient to low, intermediate, or high based into the 0 to 1, 2 to 3, or 4 to 6. And you can see here on the right side that both from the German group as well as from the British Columbia Cancer Agency, nice stratification of those with the high risk in a blue and intermediate green, and also in the low group with the CNS involvement according to those factors. However, one of the this model was criticized. It just only taking in account the IPI plus the renal or adrenal, but there are other things not counted in this as the other extranodal sites, especially testicular, breast, uterine, ovarian. Also, it was not taking in account also the other biomarkers or biological biomarkers like the CMYC, BCL2, even in double or triple hit. So most of the positive predictive value for that model was about 12%. And you can imagine in your practice, without the renal adrenal, how many patients will be in that group of more than maybe I would say 2 factors just based into the age and poor performance status. And if you're going to give a prophylaxis for those patients, then you will end it by having a huge percentage of your patient receiving a high dose methotrexate. Other biomarkers also and other studies from Goya trial from the National Cancer Research Institution in UK also reported their experience with the high numbers of patients, more than 1,000, and you can see the average 2 years CNS relapse rate between 1.9 to 4%. That's in average. However, those with the low risk, it's less than 1%. Intermediate risk is into the 2 to 3 or to 3.5%. And those with the high risk, 10 to 12% risk of CNS based into the factors. So what other clinical markers also studied or reported? Extranodal site, more than 3. It says that the risk of the CNS involvement may be a 15% or more, even that will be in a 10% of patients with diffuse large B-cell lymphoma, kidney, testicular, uterine, breast, and you can see there is also a higher chance of the CNS relax just only by having a single maybe extranodal involvement. That's in addition maybe to the other IPI. Other also biomarkers is the CMYC, and we know into the double or triple hit that will reach about 50% CNS involvement. Also the ABC, diffuse large B-cell lymphoma, 7 to 9, and the other CD5 also studies about close to 13% risk of CNS involvement. However, we are not maybe doing this or involve that into the risk stratification of our patient to estimate the risk of the CNS. This is one of the study, and this is from the Goya study also. They included the CNS IPI with the ABC cell of origin, and those patients who have both high IPI and ABC cell of origin, the risk of a CNS involvement up to 15%. Intermediate, either one of them, about 4.4, and those neither high CNS nor the ABC cell of origin is 0.5. So is there a rule for the CNS prophylaxis? And that's the question, I think, important, and I will start with the intrathecal chemotherapy. So until this time, just to again state it to what was mentioned earlier, there is no randomized clinical trial either for any methods of the high dose methotrexate versus intrathecal among those with the CNS IPI. Most of the studies will be presented today are either a retrospective, single studies, or maybe again underpowered studies. So intrathecal, it was largely extrapolated from the patients with the Burkitt's lymphoma and lymphoblastic lymphomas. There is a pooled analysis, and that was used between 1960 and 1970s, and a pooled analysis of almost 974 patients from a French group, mainly with the GILA and H9, and H7. They used this French protocol, which is the ACVBP protocol. In those studies, they were testing 3 versus 4 or 2 versus 3 weeks. The CNS prophylaxis was the intrathecal 15 milligram in day 1 and 5 of the first cycle, and also in addition to 2 courses of intravenous methotrexate. The CNS relapse 2.2. So, however, that's a pooled analysis, and we don't know if this is due to the intensification of the upfront therapy. Is it because of the high dose methotrexate? We don't know what are the factors in that study. Another study reported at 259 with a diffuse large B-cell lymphoma, 20 persons received intrathecal methotrexate, and the risk was 1.1. So those are the studies. People, they might say there is a benefit from the intrathecal chemotherapy. However, this is a systematic review on the efficacy of the central CNS prophylaxis with a stand-alone intrathecal chemotherapy in a diffuse large B-cell lymphoma. And this is a 3 post-hoc trial analysis from the landmarks as the Recover, RCHOP 14 versus 21, and the Goya, and 1 prospective database and retrospective series. So they collected more than 7,300 patients, analyzed. Almost 12% received just only a stand-alone intrathecal methotrexate. And the cumulative CNS relapse ranged from 1.9 at 6.5 years to 8.4 at 5 years, and 73, which is very important, in the parenchymal. So, and that's usually the debate, is that intrathecal will maybe reach the parenchymal brain lesions. So none of those studies showed a reduction of a CNS relapse rate with intrathecal by a univariate or multivariate analysis. So despite some report into the prophylaxis and the benefit of intrathecal, it's very difficult due to the retrospective nature of those studies, variability into the target population, number and timing of the dosing, and the concomitant delivery of intravenous high-dose methotrexate. So it will be difficult to say if it's working or not. So what about the intravenous high-dose methotrexate? Widely used, conflicting data on its efficacy, and I will just go through few studies. However, there is no randomized clinical trial yet in a high-risk patient. Different front lines in those studies in terms of the R-CHOP, R-CHIOP, ACVP, R-Codex-MR, even for diffuse large B-cell lymphoma. So we don't know exactly if that reduction in a CNS rate was due to a controlling of a systemic disease or because of the CNS penetrating region. So we'll go first through the study that reporting a benefit from the high-dose methotrexate. And this is one of the studies was reported in 2014, where the about more than 200 patients, the risk factors were the extranodal sites, elevated LDH, or other extranodal sites as a bone marrow, breast, kidney, adrenal, paranasal sinuses. Even as a small study, but those patients who received R-CHOP plus intrathecal only, 49 patients, the CNS relax was about CNS involvement, almost 18% with intrathecal. R-CHOP, intrathecal, and 2 doses of high-dose methotrexate in 125 patients, the risk was 6.9. Those who used upfront, like R-Hyper-CVAD or R-Codex-MR containing intrathecal or high dose, the risk was 2.3. However, that was just a small part. But I think one of the studies and clinical trials is evidence into the high-dose methotrexate came from the International Extranodal Lymphoma Study Group trials. And that's primarily was into the testicular lymphoma favoring a high-dose methotrexate. The initial study by the group was initially on a 373 patient. That was a retrospective nature. In those patients, because the rituximab was not available at that time, they treated with a CHOP or the MACOP or the PROMACE. However, the CNS relapse in those patients was about 15%. They received just only intrathecal. And the next study was in the limited, and it was a prospective study with the same group, that's the IELSG10. They included 53 patients. They used R-CHOP with the contralateral radiotherapy to other tests, plus just only intrathecal methotrexate. That was time for. However, the risk reduced to 6%. With the latest trial, which is the SG30, again, 54 patients. They included also advanced stages. They added here also the intrathecal cytarabine plus the high-dose methotrexate, and the CNS relapse was 0. So this is one of the evidences. It says that the high-dose methotrexate working into the CNS prophylaxis. However, I think the testicular lymphoma is maybe different in biology from other extranodal disease. It will be difficult to go through all the studies, but just summarized here. So we've seen here a lot of the retrospective single center included between 200 to 140 and 60 patients. It says here that the risk with the high dose methotrexate was reduced, as in this example, those patients who received the high dose methotrexate with or without intrathecal, there was no CNS relapse compared to those who did not receive. Also, into the other study reported in 2017, they used the high-dose methotrexate 3 gram. Median follow-up was 65 months. The CNS relapse in a high risk was 0 out of 24 with the high-dose methotrexate. Those who did not receive a high-dose methotrexate, the risk was 20%. So again, too difficult to interpret those studies given the retrospective and single center experience. On the other hand, there are multiple studies that says that there is no benefit from a high-dose methotrexate. One of them is an international retrospective study in a patient with aggressive B-cell lymphomas and a high-dose methotrexate. It was collected about more than 2,300 patients retrospectively, and they aim to see if there is a CNS reduction from a 10% to a 5% with the high-dose methotrexate. And can see the inclusion criteria here. They included diffuse large B-cell lymphoma with IPI 4 or 6, high-grade B-cell lymphomas, breast and other extranodal involvement, and they excluded the CNS involvement at the time of the diagnosis or previously treated. In that study, about 33 patients were missing data for them, so they ended by having more than 2,200 patients. The CNS IPI 4 to 6, about 91%, R-CHOP given in 93, and you can see those with no high-dose methotrexate, the risk was 9% in those patients, and those who received the high-dose methotrexate was almost 8%. So in that study, it says there was no differences. However, in the absence of the definitive data and the decision to offer prophylaxis should be personalized based to the patient. That was the conclusion in that study. Again, multiple studies here showed when they compared to high dose versus no high dose, it showed there was no benefit from adding a high dose methotrexate to a certain patient of a group. However, we have to take in consideration that each single center, they are using their own criteria for a CNS definition of risk definition for the relapse. So other prospective trials also intensified frontline combination, because we have to make this distinction between controlling the systemic disease and isolated CNS involvement. Because if you have a systemic with a CNS involvement, it means that this is a failure of a systemic control rather than this is just only isolated CNS involvement. And in this study, you can see a CHIOP 14 with 6 intravenous high-dose methotrexate. The risk was about 4.5% in this group. This is another study also including the R-CHIOP with the intrathecal liposomal ERA-C and also a high-dose methotrexate, and the risk of the CNS progression 2.3%. This is another upfront protocol intensification using the ACVP, that's the French protocol as mentioned previously, compared to the CHOP. So there is a reduction. So is that because of the upfront induction therapy, or this is because of the high-dose methotrexate? The same for, this is the last maybe studies was reported with this regard with the intensification by Macmillan and the CNS IPI score 3 to 5. They used the R-Codex MR. The risk was 3.6%. So what about the timing of a high-dose methotrexate delivery? This is reported and published this year in the Blood by Wilson, and I think that was presented in one of the ASH meeting in the 63rd ASH meeting, where they reported the experience of 1,384 patients retrospectively collected with a multi-center international, and they divided them to those who received a high-dose methotrexate during the chemotherapy. We call them intercalated or alternating with the high dose with the R-CHOP, or at the end of the therapy they received the 6 cycles R-CHOP and then they started to get a high-dose methotrexate and there was no differences. This is still, that gives maybe for those, because the concern usually with giving the high-dose methotrexate with the R-CHOP is the risk of toxicity and delay also of the R-CHOP, which is the upfront therapy. In that study, they found about a delay of 7 days or more of R-CHOP was in about 20 persons who received the intercalated high-dose methotrexate, during the R-CHOP chemotherapy. So, challenges for evidence for CNS prophylaxis is the heterogeneity of the diffuse large B-cell lymphomas, variable risk assessment for CNS involvement, multiple methods of CNS prophylaxis, relative rarity of the CNS relapse, and numerous small and underpowered observational studies. Selection bias, also a patient receiving a CNS prophylaxis tend to be younger and different also from those with no say. And there is, I think this is a loss of aversion, which I think as a clinician, we are concerned or maybe an anxiety from losing that thing and comparing to a pleasure from again. What I mean is we received or we perceive that the risk of not treating a CNS relapse has often outweighed the lack of evidence regarding this, because still with all these data that we know, we still considering high-dose methotrexate. And I think I wouldn't say maybe we are treating ourselves, but it's a concern about having this maybe as a complication for those patients, knowing maybe the poor outcome. This is a proposed algorithm by Kerry Savage, was published in 2017. Those with the low risk group, no need to do a CNS screening or prophylaxis. With the intermediate also, no need, except with a certain extranodal involvement like testicular, adrenal, uterine, or those with the CMEC positive. Those with a high risk, it should undergo routine CNS diagnostic, and prophylaxis should be given for those patients. So this is just introduction about the CNS, where we are. That's a kind of introduction to our experience, and this is the outcome of high-dose methotrexate in our population. We just wanted to know how are we doing also compared to what was reported into the literature. So the aim was to determine the outcomes of a high-dose methotrexate CNS prophylaxis in the intermediate and high-risk people only. So we've excluded all the low-risk using a real-world data from our center. So this is done over a 10 years retrospective study. We included those with the biopsy confirmed diffuse large B-cell lymphoma. The definition of the adult in our country is 15 or more. That's why we are including a 15 years. Intermediate to high risk IPI only. We excluded double and triple hit Burkitt's lymphoma. We've excluded also those with the CNS involvement at the time of the diagnosis. So a high-risk group in our patient was defined as those who had a testicular lymphomas, epidural disease, sinus involvement, bone marrow, renal, and adrenal. Those are the patients we are usually considered to give them a high-dose methotrexate if the CNS workup is negative. However, if it's positive with the MRI or flow cytometry in the CSF, we treat them as the CNS involvement. And the prophylaxis we are giving is the high-dose methotrexate, 3.5 gram per meter square, and on a day 10 and 15 post-R-CHOP, following a completion of chemotherapy for a 4 to 6 cycles. So we are giving it as intercalated for most of our patients. Try to give it after cycle 2 and 4, and to give maybe 2 to 4 more. Sometimes intrathecal was used, considered in a synchronous and early CNS relapse based into the physician discretion, but those patients were excluded, were not. So 358 patients meeting the criteria with just only intermediate and high risk according to the CNS IPI. And CNS prophylaxis was given to 32 patients, which is a small number, and 326 did not receive. If you see the maybe the differences into the baseline characteristics, you can see those who receive the CNS prophylaxis tend to be a younger compared to the patient who did not. Also extranodal site, as you would expect, 93 compared to 64, because we are considering those testicular and other patients. And also the stage of the cancer was advanced stage in 90%, compared to the non-high dose methotrexate, abnormal LDH also. And most of our patients here, like a 50-50, were a high, according to the CNS IPI, either high or intermediate. So a 10 CNS relapses only detected in that 358, which is lower compared to other series. But however, that's also comparable if you see the UK NCRI data for more than 2,000 patients. They have the same, maybe almost 2% of those patients. And interestingly, those patients who received the high dose methotrexate, they had more CNS relapse. So 12.5% compared to 1.8 in those with a non-CNS prophylaxis group. So is that because we are selecting a very high-risk patient? Is it that will put up also a question about the efficacy of a high-dose methotrexate? But in this thing, we don't have a comparative arm, especially in that group, saying those patients who received high-dose methotrexate versus no high-dose methotrexate. So is that 12.5 reduced from a higher number, or this is seems that there is no benefit from the high-dose methotrexate? You can see here the differences into the relapse rate between the two groups was statistically significant between the patient who received the high-dose prophylaxis compared to those who did not receive. The 10 patients who had, in general, tend to be advanced stage. Non-GCP was in about 70%, high CNS IPI and 70%, and those are just the clinical characteristics. This is the overall survival post CNS relapse, and that's also in alignment with what was reported. The median time to a CNS was 8.5. So it's also those patients who had a CNS relapse had it within the first 6 to 9 months, ours 8.5 months. The median overall survival post CNS relapse was 8 months. So a very devastating complication for those patients. In a univariate and multivariate also analysis, the only factor was of a clinical significance is the systemic relapse into the univariate and multivariate, but the other as the CNS IPI and CNS relapse and stage of the disease did not have that significant or did not maintain the significant into the multivariate. So this is the overall survival for the whole group. Those are the patient no relapse, and you can see those who had relapse disease for sure, they will have a poorer overall survival compared to those with no relapse. Progression-free survival for the entire cohort, we have 59 patients, 20 persons, which considered to be good also as a failure from the systemic therapy. The median time to the systemic relapse was about 18 months, and you see the median progression-free survival was not reached. So strength and limitations. This is relatively a large sample size of 358, just only intermediate and high risk group. Limitations, it's for sure a retrospective design, lack of a comparative group to those received the high dose methotrexate, and lack of CNS assessment for all the patients at the time because they had this intermediate or high risk group. However, I think if I will take it in the positive way that now we had many patients intermediate and high risk, they did not receive high dose methotrexate, which also concur with the with what was reported that not everyone on CNS IPI intermediate or high risk they should receive a high dose methotrexate. So in a conclusion, a prospective data on a risk estimation and benefit of CNS prophylaxis are needed for sure. We have to focus on integrating a molecular like the ABC, the clinical risk factors, including the extranodal, CNS IPI, to identify those with a high-risk patient. Maybe expanding into the ultra-sensitive technology as the circulating DNA or the MYD mutation testing for the CSF to maybe detect initial occult CNS involvement, and there have been a few studies on this. A reduction of the CNS dissemination by using active agent against diffuse large B-cell lymphoma with a good CNS penetration. Also, a reported experiences from different centers into the lenalidomide BTKs, a novel approach of management of the secondary CNS lymphomas as CAR T-cell that might also change the game. So that's why I was saying I wish I can start with the conclusion, because at the end that question was not clearly answered and that chapter was not closed. Thank you so much.